We discussed the use of continuous anesthetic infusions versus intermittent boluses of medications for the treatment of refractory status epilepticus. Status epilepticus is a continuous ongoing seizure that does not stop on its own. And we actually defined our patient group as having failed at least 2 traditional seizure medications. And so after they failed that, we wondered what medications should be attempted next and how effective they were. A lot of times there are definitely situations in which patients may have something more severe like meningitis or something like that, and it seems that the medications don't work. And it's like everything else, there's a certain group of patients in a biologic system where the medicines just don't work. And so in our study, we were actually looking at dichotomizing these 2 groups because there's been some discussion about after you fail 2 medications, should everybody go to a continuous infusion where they get either continuous midazolam or continuous pentobarbital. And recently, over the past few years, there's been 2 publications that suggested using a continuous infusion in and of itself increases your mortality regardless of etiology. And so the question was, should we really go to continuous infusion, as many of us tend to do, or should we continue to try intermittent medicines like levetiracetam or valproic acid or one of those? So what we found is that there was not a big difference between the 2 groups. So traditionally we would have thought, oh well, we're just going to treat them with midazolam, we're going to dial them up, it's going to make their brains flat, that's going to work great. And we did not find that there was a big difference in that. And actually, we found a subgroup where the patients who, once they reached the study hospital, which was part of our status epilepticus research group, once they reached the study hospital, for those patients where they had seizures more than 30 minutes, actually the group that received the continuous infusions actually took longer to get control than those who received intermittent doses of medications. I think that's a small subgroup, not a great number of patients, but it was statistically significant. I think the main thing was, to me in my mind, is that the lack of difference is fairly important, because I think traditionally we have a hard time watching children have seizures, right? If moms are freaking out, we're freaking out, we want to stop them fast, we think continuous infusion is the way to go because fine, we put a tube in to breathe for them, we control their airway, we do all that stuff. I think the challenge, of course, with that is that once you go the continuous infusion route, what we did find is that you were much more likely to experience adverse effects. And so the morbidity was higher, so you were more likely to require pressor support because of low blood pressure. You had a longer length of stay in the ICU, so it was 10 days if you received a continuous anesthetic infusion versus 2 days if you received intermittent boluses of anticonvulsants. And that in our group of 111 patients, 3 patients died. All of those received continuous infusions. Now that isn't to say that there were other factors, there may be other factors that go in that. I think it's hard to assess for severity because there's not a great way to account for etiology and some of these other things, and we didn't have enough numbers to kind of tease that out. But at least in our mind, it then asks, okay, we have a real good idea of what the first seizure medication should be for status, and that's going to be a benzodiazepine. We have a pretty good idea of fairly limited number of medications for the second medication, but then what do we do next? Like I said, traditionally we tend to go for continuous infusions or other medications, but maybe we really need to look at that. Maybe we do need to have an arm, that there's enough equipoise between the 2 groups that maybe we do need to have a continuous infusion arm versus phenobarbital or valproic acid, and see how those sort of drop out. We were strictly pediatrics in our group, so we did go up to 21, but I think for the majority of our median age was quite low, 6 or something. But definitely I still think it's early to make clinical practice changes, but I do think for us it provided enough preliminary data that makes us think that we really need to go that next step and have a study that maybe looks at comparing those 2 arms, continuous anesthetic infusion versus another anticonvulsant. If it looks like they really work about the same, clearly the side effects of the continuous infusion was much higher, and so it really doesn't warrant going that route. However, like I said, preliminary numbers, not great, not a huge amount of data. You really need to be able to control for some of those variables that we couldn't do in our study, and you really need to have more of a randomization to that, which we just aren't able to do. It elevates the stress in the room, for sure, because as you mentioned, in many cases, these children may have never had a seizure before, and their parents are completely freaked out. They automatically think the worst. And so I think that sort of makes us be a bit more aggressive than maybe we need to be. But at the same time, we've also found one of the big things from our research group was the biggest predictor of whether a seizure stopped was how quickly you gave your medications. So in other words, if you gave your benzodiazepines early like you were supposed to, and then followed it with another medication, and then followed it with another medication within a short time frame, those people didn't necessarily need to go on to receive a continuous infusion. So it's a bit of a bit of a dichotomy there. We want people to be treated early. I don't know that we necessarily always need them to be treated aggressively with intubation and all of those kind of things. That's always a difficult situation, and I always feel for families because it's almost always so frightening, right? I mean, you're always thinking the worst, and so what we try to tell them is, we need to make sure that we can control as many of the variables as possible. If they're having problems with their breathing, we need to be able to control their breathing. We need to make sure that they're getting oxygen and nutrition and things like that. The good news is we can stop seizures in almost all cases. I mean, I can dial up the medication and they stop. The challenge is really sometimes getting at that underlying cause. So if you've had a stroke, if you have meningitis, doing those things to treat that underlying cause is oftentimes very critical once you've kind of controlled their seizures. Unfortunately, a lot of kids, we don't have a good reason for it, and so that's where it gets really challenging is once you're thinking about something like, do we try steroids because nothing else has worked or something like that, and I think that's pretty challenging. It's frustrating for families and it's frustrating for caregivers, right? Because we want to do what's best, and right now there's not great data out there. Like I said, our first drug, there's great data to show it works. Second drug, there's a study that's out there right now that's ongoing that's going to try to answer that question for us. Anything beyond that, it's unclear. And so as physicians, that uncertainty, especially for neurologists, because we all have a little bit of OCD, is really pretty challenging. So what we're hoping to do is try to get together a proposal to kind of look at that third level drug and sort of randomize patients so that we can kind of control some of the variables moving forward. Having a large research group like we do with our status epilepticus research group has been very helpful to sort of achieve some initial numbers. We've shown that we're effective to work as a team. It's probably good to kind of get that next step and some funding to support that.